So hi everyone, my name's Ashish Thakrar, as Dr. Salisbury Afshar mentioned, I'm an internist, I'm an addiction specialist. I focus a lot of my research on trying to understand how treatment has changed as the supply of unregulated opioids has changed. And so this topic is, pretty much directly drawn on a lot of my experience and research. I think it's important to just situate where my background is from and where I'm from. In that I did all of my medical training in either Philadelphia or Baltimore. And I think the supply of unregulated opioids is really different in different parts of the country, as I'm sure all of you know. But I think it's important just to mention that and to, have that just be upfront to say that my experience is likely going to be very different from folks like yourselves who are in the Midwest or folks who are in the Southwest or West Coast. So with that, I'll get started. I would love for this to be as interactive as possible. Right now, I can just see one person in the back of a conference room in 147. Hi, thanks for having your video on. If anyone feels comfortable having the video on, it just makes it a little bit easier, but no pressure. I will also put my email in the chat just so you all have it there. I'm always happy to chat more about this topic. If you have any questions. So with that, I will start my slides.
Ashish, I will just tell you quickly, I also trained in Baltimore. I always forget we have that overlap, but I would say just for context, Madison area, I've only worked here for 3 years. In the 3 years I've been here, really all of our toxicology data from clinic, hospital, and then all of our overdose death data, right, which are just points, not necessarily exactly, it is pretty much all fentanyl. It's not like the West Coast where it's like still a mix. Occasionally we see heroin, but it's only in the context of fentanyl. The big difference for us is that we are not seeing a ton of xylazine, hopefully ever, but yet somewhere a little bit less probably than 10% of overdose deaths that have been sent full toxicologies on, which is mostly coming out of our bigger cities, have had any amount of xylazine. So it's definitely not at the scale of what I'm assuming you guys are probably seeing there. So just for context.
That's really helpful to hear. Thank you. Yeah. I've got no disclosures, no conflicts of interest. The objectives for this talk, I'd like to describe what some of the challenges are with buprenorphine initiation, talk about how to formulate a plan to preempt withdrawal that might come up with non-opioid medications, discuss the use of low and high dose approaches, and then share an approach to shared decision making and trying to select which patients to use with what approach to use with which patients. And so this is going to be the outline of the talk to try to get to those objectives. Start with what's going on. I'll try to present a summary of what we know from the evidence, mix of some anecdote, patient experience, and epi data, and then what we can do about it. So to get us started, before I actually get us started, this is a summary that just came out in the Journal of Addiction Medicine. I think it's a really fantastic resource. So I put this up front just to say if any of you are interested in exploring more, it just was published online, I think a few weeks ago. And I think it's a very helpful summary statement about buprenorphine approaches in the era of high potency synthetic opioids. So what is going on here? I think this all started like so many things in addiction with patient reports. And I want to start and situate us here with patient reports because I think it's important to prioritize what their experience is. I think our responsibility as clinicians is not to just end with saying, oh, patients are reporting this, so that's 100% exactly what's happening. But I think we have to start with that and be really respectful that our experience as clinicians doesn't capture the full patient experience, right? And I think this started with patient reports of things being different. Has heroin shifted to fentanyl? This was a qualitative study of people who had opioid use disorder in Ohio. And as part of this qualitative study of how things changed in the era of fentanyl, they asked patients about their experience with trying buprenorphine. And I think this quote from a patient summarizes what I heard very frequently during my addiction fellowship in Baltimore, which is, yes, for me, buprenorphine sends me into precipitated withdrawals every effing time I try to get off fentanyl. Then I have these sub-doctors telling me it's not real. And it's like, hey, go effing ask the people who are buying it off the street. It is real. I waited 80 hours between the last time this woman used fentanyl and bup. And even then, she said she felt like she had what she described as precipitated withdrawal. This was, I think, further built on in this perspective article by some folks at Yale who partnered with people in drug users union, two different drug users unions, plea for people who use drugs to clinicians, that because of some of these challenges that fentanyl seem to be introducing, we need new ways of starting buprenorphine. And the last example of this, because I think this just manifests so well, is it was actually from the Wall Street Journal, where they interviewed a woman who described going into a residential treatment program. She was started on buprenorphine by a clinician, so this isn't her going buying off the street. And in her experience, she said, I was literally ripping my hair out. Every time I took a breath, it felt like something was ripping my stomach. This experience that she felt made her feel like I want to die. That's how bad this was for her and how serious it felt like for her. So we're going to start with that, saying, all right, patients seem to be reporting something has changed. What is the clinical evidence we have of this, and how can we maybe more objectively see what is involved in this phenomenon? There have been a few different case reports or case series describing this precipitated withdrawal happening. I'm going to show some graphs from one of them that I was a collaborator on that was published recently. This looked at patients in the emergency departments at Penn hospitals in Philadelphia over a year. And we collected what clinicians told us were examples of precipitated withdrawal. There were a few of us here who just get email and saying, oh my God, I had this horrible experience, precipitated withdrawal, and we just collected those cases. Very biased sample, in no way representative, but we wanted to look at, what could we actually see as objectively happening in these cases that others identified. I will not go through all of these plots. I'll just highlight the one on the top left, where you see in blue, this is a patient whose COWS score before buprenorphine was 9. And then there was one right after that 9, the one right before the buprenorphine was between 10 and 15. I think this is probably 13 or 14. So what I think most of us would say was a very adequate COWS score before bup. Patient got 8 milligrams of buprenorphine. That's what this X is. And then within an hour, the next COWS score was between 20 and 25. I think any of us looking at that would objectively say that's precipitated withdrawal. There are a few other examples of that here. There are also a few cases that other clinicians said, oh, we think this is precipitated withdrawal, but when we looked at it a little bit more closely, looked like more just protracted withdrawal that didn't seem to get better despite 2 or 4 milligrams of buprenorphine. So it seems like patients are telling us something different is happening. There are at least a few cases where it looks like objectively we can say this is some example of precipitated or protracted withdrawal. But then the key important question is, how often is this really happening with a traditional buprenorphine start? And I'm going to show what I think is the most rigorous analysis of this, which was published in JAMA Network Open. Gail D'Onofrio et al. Dr. D'Onofrio was the first author on this, and it's a multi-site clinical trial of starting buprenorphine in the emergency department. It's actually a trial for Sublocade, but obviously in that process, I think it's a trial of Brixadi, but either way, it's in that process, they're starting bup for patients in the ED. Multi-site, and they get COWS assessments before and after bup. They had 76% of patients who were fentanyl positive, and only 1% experienced precipitated withdrawal. So this multi-site study seems to indicate that what a few patients are reporting is actually really, really rare. And I think some of these authors I've heard speak and others might say, look, more and more patients are getting buprenorphine because treatment is expanding as it should. These rare instances of precipitated withdrawal always were the case. Now they're just getting more attention because the base denominator is going up. And even if the 1% rate is consistent, there's just more number of people total having this experience. It's not actually a shift because of fentanyl. I, based on my experience and my interpretations from these other studies, believe that it's maybe a little bit different from that. So I'm sharing this paper that I was part of that was published in Journal of Addiction Medicine. And in that, we asked patients who are entering residential treatment what their experience is like with buprenorphine. And we asked them if they were using fentanyl. So this is only self-reported fentanyl use. And if they were using fentanyl, how many patients had severe withdrawal when they took bup after fentanyl. And what we saw was that more than 33%, more than a third, about 37%, reported severe withdrawal when they took buprenorphine after fentanyl. So this, lots of limitations, self-reported data. We asked patients how long they waited, and it seems like the odds of severe withdrawal were still higher despite waiting 24, 48 hours. But again, all self-reported. But I think this captures what the patient perception is right now. which is you're having more than a third of patients saying they personally have an experience of severe withdrawal when they took bup after fentanyl. What is the true incidence? I don't know. I don't think any of us really know, and I think it's a hard question to answer at a national level. So I'm putting this in a little box to, clarify this is my editorializing and interpretation of these conflicting data and reports. I think that there's a lot of variability in the drug supply. Not just a question of whether fentanyl is present or not, as Dr. Salisbury-Afshar mentioned, but what is a quantitative level of fentanyl that's out there in the dope supply, right? Is it just that there's some, like maybe 2% fentanyl mixed in with other filler or mixed in with xylazine? Is it 40 or 50% fentanyl? I think we have a lot more nuanced understanding that we need to develop through drug testing to understand that. I think there's also a lot of variability in both patient and provider expectation. I've seen both sides of this, and patients really, really nervous, and what might be discomfort in other contexts ends up becoming true precipitated withdrawal for them. I've seen the other side too, where you have providers who are very cavalier about starting bup. And then when I come and assess the patients, all of a sudden I'm the one who discovers, oh, they have really rip-roaring precipitated withdrawal, and the provider caring for that patient just hadn't noticed. So I think a lot still up in the air, but something different seems to be happening. Why would something different seem to be happening with fentanyl compared to heroin? It's a different molecule. And despite our experience with fentanyl in ICUs as being fast on, fast off, we're seeing some early evidence that patients who have chronic exposure to fentanyl seem to take a longer time for it to terminally clear in the urine, more than 1 or 2 days. In fact, this study showed patients in a residential treatment program took on average about 5 to 7 days for the fentanyl to terminally clear in the urine. So the fentanyl continued to be positive for on average about 5 to 7 days, despite patients being in a residential treatment program where they presumably weren't continuing to use. This was corroborated by this other study that was in addiction that showed that patients continue to have fentanyl positive urine in a residential, I think this is a trial setting, for more than 5 to 7 days despite abstinence. So part of that could be because fentanyl is so lipophilic. It was actually first invented because the chemists were looking for more lipophilic opioid that would cross the blood-brain barrier more quickly. And it seems like it seeps into skeletal muscle and adipose and probably builds up stores there. So even though some patients have Cal score of 8 to 10, my suspicion is that there's still enough of a baseline amount of fentanyl agonism that puts some patients at risk of precipitated withdrawal from bup. I don't know if that number is 1% or 33%. I think it's probably somewhere in between for the patients I've seen in Baltimore and Philly. I want to pause here, and I know I'm talking to a group of addiction medicine experts, and I'd love to hear, this is a controversial topic. I'd love to hear your experience, if you have any thoughts on this and some of the data I presented, and kind of open up the floor.
I'll share a brief anecdote. So before I came to this job, I worked for a not-for-profit consulting firm, and so I did work all over the country, both in the public health side and the clinical side. And we were working on a project in Delaware, and there was an addiction doc there who felt really strongly that outpatient initiation should never happen anymore because everyone was going to have precipitated withdrawal. And because I was in the Midwest, I was like, oh gosh, like this was at least maybe 3 or 4 years ago, 4+ years ago. And I said, well, I better do a survey of all my East Coast colleagues because maybe to your point, like there's so much geographical variation, like let me reach out and sort of, so I talked to folks from, and it was informal, it wasn't for research. It was truly just like, I need to figure out how to guide these folks in Delaware, all the way from Massachusetts down only to about DC area. And I think I got lots of feedback from lots of people with different perspectives. But the one that was most helpful was actually from Ruth Potee, who you might know. But she was like, Elizabeth, look, I work in a jail, I work in a detox, and I still see some people outpatient. And so I have the luxury, right, in this sort of setting to like watch people in these very controlled settings of detox and jail. And what her point, what her stance or what her experience was at that time was like, I cannot predict it. like everybody seemingly, she's in Western Mass, so it's, there probably aren't that many different drug markets there, seemingly has the same drug supply. And so it doesn't seem to matter how old they are, how obese they are, right? If we're talking about adipose tissue, it doesn't seem to matter how long they've been using or how much they're using. There's some subset of people who you just have to wait longer. And they usually know, and they usually tell us.
Yeah, they do.
But I cannot figure out how to predict it. But we're seeing, she's like, it's a minority. It's definitely not 50%. She like didn't want to put an exact number on it, but it's a minority, but it definitely happens for a small subset of people. And then everybody else seems to do fine with the traditional way. And I think it's been really interesting to kind of see this coming out in the literature, and and then all experiences and how to sort of different approaches in the outpatient setting and some of the challenges around that. But I think it's been interesting to me to hear, and this is what you and I emailed about, like what's people's subjective experiences versus when they're in a controlled environment where we're like watching them and monitoring them very closely. Sort of, it does, to my experience has been that sometimes there's so much anxiety around what may happen that some patients really perceive as being withdrawal. And then there is absolutely some precipitated withdrawal that happens, especially when we start medicine soon. So
I think that captures perfectly, where I was going to with this, which is that I would describe it almost exactly like you said. There seems to be precipitated or protracted withdrawal for a minority of patients. I don't really know how to predict which patients those are going to be. Exactly like you and Rithpodi said. So it does introduce some major challenges for how do we respond when we don't really know where the patients are going to struggle, right? So I think one important point is thinking about preempting opioid withdrawal. This is kind of like relearning old tricks. If we look back in the textbooks, pre-buprenorphine and how you treat opioid withdrawal, we have all this, non-opioid medications that seem to work pretty well for opioid withdrawal symptoms. Certainly not as well as buprenorphine, so I'm not saying they replace those, but we still have those available. And I think when I trained during my residency, I kind of ignored those because I just thought we're going to replace the opioid agonism with bup. So, shouldn't focus on those. Now I think it's kind of relearning to use those as a supplement and adjuvant. So I think with, underlying this with heroin or oxycodone, I could be really confident. And I still sometimes see patients with oxycodone dependence. 8 hours later, I feel confident. I know that oxycodone's gone and I can start it. Now we're trying to preempt withdrawal. So clonidine or lofexidine, if covered by insurance, I think it's the best single agent we have that's supported by some really good RCT level data for opioid withdrawal. So I tend to start with that for patients who can tolerate it with their blood pressure and heart rate. And then the others, I kind of focus on what the opioid withdrawal symptoms are that the patients have. And this is where there's, again, a lot of variability. Some patients, it's the GI upset that's dominant. For others, nausea. For others, the muscle aches. And what I tend to do if I'm doing a traditional induction is I'll arm the patients with normally an alpha-2 agent like clonidine and at least one other med to say, hey, here are 2 meds you can take if things start going south. You have clonidine and Zofran, or clonidine and loperamide, whatever it might be. I've also started exploring pre-medicating patients a little bit, especially with clonidine. This is not evidence-based yet, I don't think, but this is more just a little bit experimenting that just through clinical practice and through other colleagues. And I do think that anecdotally it seems to help a little bit. There's also a trial that hasn't been published yet that was done at the VA here in Philly where lofexidine pregabalin as a combination was very effective for opioid withdrawal in patients with fentanyl dependence. And these are patients who are going to start naltrexone, so they weren't using an opioid agonist. So just hearing about those trial data, still haven't been published. I do sometimes think about combining like clonidine and a gabapentinoid as pre-medicating patients. Just something to consider, though. So that's for standard inductions. Then what about these alternatives, low dose and high dose induction, which have emerged in the literature over the last few years? I'll start by definition of low dose initiation. It's sometimes called microdosing or microinduction, lots of different terminology for it. The basic idea is that you are going to administer small and gradually increasing doses of bup while continuing a full agonist opioid. This is typically done over about 2 to 7 days. The goal of this is to start buprenorphine maintenance without requiring or precipitating withdrawal. This is an illustration that was in a review article by Ghosh et al. That I find helpful schematic. You see here on the left side, the left panel, in orange, a full agonist. Let's call it oxycodone for now. And then in blue, you have buprenorphine. You're starting at a period where most of a patient's opioid receptors are occupied by oxycodone. You can maintain that oxycodone at, let's say, Q4-hour dosing. So that's steady state. And you slowly introduce buprenorphine in blue. You slowly replace that oxycodone over 4 days. If you do that at a slow enough rate, slowly just replacing the bup, then by the end of day 4, you've replaced all of the full agonist oxy with partial agonist buprenorphine, and you slowly have moved them onto buprenorphine maintenance without requiring a precipitating withdrawal. There are much more detailed pharmacologic explanations of this that don't rely on this kind of a schematic. JP D'Aquino is the first author on one that I find very helpful if anyone is interested in exploring that. What are some of the common elements of low dose induction? There are, as many different case series have been published on this, there are that many different dosing approaches, but here's some of the common elements. They almost all start at 0.5 sublingual or lower doses, or the equivalent in different formulations. It doesn't seem like the formulation you use really matters, whether it's patch, buccal, sublingual, IV. Getting some amount of bup in a small enough dose is what matters, and I typically start with 0.5 or the equivalent. Maintaining full agonists throughout the transition is really important, and I think I have a little Mythbusters thing here, because I've sometimes heard the low-dose initiation described by, I think it's mostly critics or folks who haven't used it, without this important part here. They'll sometimes just talk about starting really low doses and escalating, but the only way this ever works is if you maintain full agonists throughout the transition. I think it's possible to start tapering full agonists by day, the last 2 or 3 days if you really need to and it's a rush. I generally don't recommend that, but you can. And then you slowly escalate the buprenorphine. Lots of different approaches to this. The approach I've had most experience with is with hospitalized patients using IV bup. I've personally done it for, I think, I'm at 28 patients or so over my fellowship. And we had lots of success doing this over about 2 to 3 days. A few approaches have done this in 1 day. Most take a little bit longer, about 4 or 5, and some take as long as 7 days or longer even. And once you're on a treatment dose of buprenorphine, so I would say once patients have tolerated that first dose of at least 8 sublingual, at that point, it's generally okay to rapidly taper off the full agonists if there's not another indication for them. And the speed of that taper really depends on the context. When I've done this, it seems to have worked really well with the taper in about 24 to 48 hours. Some patients, though, need it to be a little bit slower than that. So what's the evidence for this approach? We now have, by my count, 5 retrospective, large-ish cohort analyses from geographically diverse areas with about an 85 to 90% success rate, with success defined as reaching treatment dose of buprenorphine without moderate or severe withdrawal. It's a pretty decent evidence base. On retrospective, there are a few trials that have already started recruitment, but no evidence from them yet. And then pair that with more than 25 case studies or case series, all in the inpatient setting for that higher level. We have a few outpatient case series, only about 30 cases. This is where I think it's important to highlight that there's a lot less evidence for how to do this well in outpatient settings. So if you think of a traditional evidence-based medicine hierarchy, which I know there are critiques of, but just if you're going to situate this there, I think of outpatient as being much higher. I'm sorry, inpatient as being much higher and I feel much more confident with than outpatient low dose initiation. And why this distinction? What's different about inpatient versus outpatient? I believe that the key difference is that you can administer full agonist opioids in the inpatient setting consistently. I think this is probably the most important distinction here. When someone's hospitalized, there are no legal limitations, generally speaking, for administering oxycodone, for example, every 4 hours. So you can maintain that full agonism and just change one variable at a time, which is the bup. The outpatient settings in the US, there are legal limitations to prescribing full agonist opioid for opioid addiction. it is illegal to prescribe a full agonist opioid for opioid addiction still. You can prescribe buprenorphine, a partial agonist, or you can send patients to an OTP to get methadone administered, but I still can't prescribe oxy for OUD. So what we tend to do, and what most of these case series have done, is they're either published in other countries, like in Canada, where patients are prescribed allotted for the full agonism, it seems to work well there, or in the US, we tell patients, hey, keep using whatever dope fentanyl that you're using. You kind of titrate the full agonist, and then we'll tell you how to dose up the bupe. And I think this is where their patients struggle a lot more. This is a chart that I kind of just have in here as a reference. I'm not going to go in detail, but this is something that a group of us put together for MRSA 2 years ago, describing different approaches to inpatient low-dose initiation. I will just highlight the column on the left, showing that there are lots of different approaches and dosing formulations that can be used. It just depends on what you have available in your hospital. Pause here and see if there's any thoughts, questions, or discussion points about low-dose initiation. Can I get a thumbs up from someone if they've had success with it, or a thumbs down if it's been poor and you're not a believer? I saw David, you moved your hand, but I couldn't see what it was fast enough. Good, thumbs up, great. Love to hear it, thanks. All right. Inpatient works great, outpatient we struggled. It's exactly my experience, yeah. So, all right, how about high dose initiation? The definition of this, I've gathered from the literature, is that after abstinence and withdrawal, the goal is to start with a higher dose of buprenorphine than in a traditional induction, generally at least 8, and to escalate to 16 to 32 milligrams within the first 1 to 2 initial doses. The goal seems to be to get to therapeutic doses faster. So rather than in the old traditional induction where you give 2, then you wait, then you give 2 more, then you wait, then you give maybe 4 more, like, let's just get patients to their treatment dose faster so that we can relieve any of this protracted withdrawal they might have. And it also reduces lengths of stay in the emergency department and emergent care settings. Right now, the evidence is largely in, I think actually exclusively in emergency department and urgent care settings. And the approach that seems to be used is to start with 8 to 16 milligrams of the first dose, and then add additional bupe doses, PRN, up to 32 milligrams in that first day. And I think most of the authors of these studies would say patients don't need to stay on 32 if they get to 32. But after the first day or two of stabilizing a higher dose, then they can transition to the more traditional 16 to 24 milligram total daily dose. This is another little Mythbusters thing I wanted to put up here. Really, you should only consider this for patients who already have withdrawal. I can't tell you the number of meetings I've been in where someone suggests, oh, can we just hit patients with 32 milligrams of bupe before they even have withdrawal? And they'll use this phrase and flood the receptor. And then, right away, if you just give them 32 before they even have withdrawal, then they won't have severe withdrawal. Should just go smoothly. I have not ever seen that done with success. I've seen patients accidentally get a lot of bupe before they have withdrawal, accidentally because it wasn't intended in my macro dose and it's gone really poorly. So don't think there's any evidence for doing this yet. And I would really caution folks not to do this unless patients already have withdrawal. There's really no evidence for safety in this approach before withdrawal starts, at least that I'm aware of, and obviously speak up if I'm missing something. So what's the evidence base? It's basically 2 large multi-site, not side, retrospective analyses from California. These studies are large and really impressive in that Andrew Herring was either the first or last author on both of them. And his group through California Bridges has done such incredible work expanding access to buprenorphine in emergency departments. And they've really pushed the needle forward on how to get patients to treatment doses faster in that setting. So they had 391 patients in the first study. And the goal of that was just to show, look, this can be safe and well tolerated. I think there was some concern that these higher doses might oversedate some patients. So I think the focus of this study, which was done actually mostly pre-fentanyl, was to show that patients did not get sedated, did not need Narcan with these higher doses. And they reported just a 1% precipitated withdrawal rate, again, pre-fentanyl. There's a follow-up study. Hannah Snyder was the first author on this one that came out recently. And in this study, they looked at patients a little bit later, and the initial doses were a little bit higher. And in this case, 10% self-reported fentanyl use and only a 2% precipitated withdrawal rate. Again, all in California. So my summary of this box for editorializing is it seems like titrating to 8 to 24 milligrams over 1 to 2 doses has really low risk of sedation. I feel pretty confident based on these pretty well done studies that sedation is not the risk that I'm concerned about. The approach likely reduces protracted withdrawal too, because you're getting to therapeutic doses faster. I don't believe that these studies are enough to convince me that the approach lowers precipitated withdrawal risk compared to traditional induction, but I think that's open to debate. I think the baseline rate of precipitated withdrawal in these settings is probably a lot lower than in the settings where I've practiced. And the authors of the Snyder et al. Paper themselves describe most fentanyl use in California at that time as being folks using fentanyl blues or smoking fentanyl blue tabs. Just very different from the white powdered fentanyl that we're seeing here, which patients have been using almost exclusively for more than 5 years, with a lot more injection drug use. So all of those might be factors. And then again, just an anecdote, this just happens to be the one case, the first case from that precipitated withdrawal case series that I described before, the same case that I highlighted. I can show you this as a reminder. This was a patient who started 8 milligrams of bup when their COW score was 13, and despite 8, they still had precipitated withdrawal. So these anecdotes, I still see precipitated withdrawal with high initial doses. And I have an extra slide at the end where we can kind of go into the details of if lower doses are better for precip. I do think lower doses are probably reduce the chances of precip withdrawal. So if the concern is PW, then I would say probably stick with lower dose initially. How about in an internal medicine setting, which is where I generally practice? So for admitted patients, this is the setting where I start thinking about using a high dose approach. If I'm doing standard induction, so not low dose approach, and I assess the patient is having a low risk of precipitated withdrawal, let's say they've been admitted for 4 days or 5 days and they're on like oxycodone, full agonist. I know how long that's going to last. And there's a rush to get them to therapeutic dose. Either they're like leaving before noon the next morning, or they themselves are telling you that this is the priority for them. Then I think it makes sense. I'll give the last dose of oxycodone at 10 p.m. or midnight, and then you can just start 8 milligrams of bup 8 a.m. the next morning. In my mind, that's just an adapted standard induction, but if folks want to call it a high dose, I think that works too. It doesn't feel that different from what I was doing normally, but I think that's great. I think an alternative works essentially more or less the same, which is that, if you're at all concerned about precipitated withdrawal, just 2 milligram test dose, give 2 milligrams 2 hours later, and then as soon as they've gotten 4 milligrams and tolerated it, you're good to go with just finishing the rest of that standard dose. And by about 4 hours after that first dose, you get to a full dose anyway. For outpatients, I think I would generally not recommend this for a patient I'm going to see in clinic like this afternoon. If I see someone who wants to start bup, I just don't have enough confidence that it lowers the risk of precipitated withdrawal. And I've seen really severe precip from 8 or 16 milligrams, whereas from 2, it seems to be milder in my anecdotal experience. And I can also share some of the more technical reasons behind that from this Rosado study and another abstract that we have coming out in MRSA. But yeah, I want to open it up again for questions. Anyone else have experience with different high dose approaches? I know I'm a little bit biased, as you can probably hear. I'll try to make that as obvious as could be, not to hide that and some of my skepticism, but I'd love to hear if folks have different experiences with this.
I've used it in inpatient successfully one time, and then one time not so successfully, but I believe that was because whoever was scoring for the cows scored higher than it likely should have been, but we were unable to evaluate the patient because it was at a different hospital, so I wasn't on site to monitor. But when I did do it on inpatient, I kind of took your approach too, where I'm preemptively treating symptoms prior to, like right when they're starting to feel nauseous, like treating right away, starting the clonidine right away. And then we waited a good long time and then did the 888 and it went well. But the other time it didn't go so well. But I think that's just because of incorrect cow scoring. So that's been my only two experiences I've had with it so far.
Yeah. Yeah, I'll share, like I've talked about this at a few other places, and some people swear by it and say like, oh my gosh, this seems to be the way to do it. And so maybe just, maybe we just need to collect more data on the exact settings.
I had a question about kind of like you were talking about like the risk of precipitated withdrawal after and like reducing like prolonged withdrawal. And I was wondering if a patient in your experience has tolerated a first dose of like maybe 8 milligrams. Do you ever see patients later then take maybe 16 and have precipitated withdrawal then? Or can we feel like more comfortable after they've gotten like an 8 milligram dose?
I think absolutely, yes. For me, the threshold that is that once they've tolerated a 4 milligram dose, I have never seen someone get, and I have not heard of that happening. So I think it's a really important point that should be researched more objectively. But in the meantime, while we need to act, I would say my threshold is once they've tolerated 4 milligram dose, they should not have precipitated withdrawal. I feel pretty confident about that. Yeah. And I see one hand up. Oh yeah.
Yeah, so I guess and for folks, I realize maybe not everybody's at UW-Madison, but I will just share, I've been working with the ER for a year and a half, and I think a lot of this literature comes from the ER. And we actually met mostly with Kate Hawk, and we're like really going back and forth. Should the first dose be 4? Should the first dose be 8? And in the end, just for folks who haven't looked at the ER pathway, we started with 4. And the reason there are lots of reasons that we can discuss at a future date, but was mostly just we were worried that if the cow score was artificially elevated, or that like, and so our goal was we'd rather start a little slower and give more than, oh, and I just lost you guys, then go too fast and precipitate more withdrawal. And so our ER protocol does start a little bit lower. And then the other thing I was going to add, and Ashish, I don't know if you have thoughts on this, is our EMS locally is working on starting it. And holy cow, the EMS protocols feel very fast to me and make me a little bit nervous. And so, there's like a couple of papers in the peer-reviewed literature on field administration, but that is something that Dane County and Milwaukee County has already started, although I don't think the last time I spoke to them, not a single patient had accepted yet, but they have a pathway that starts at 16 milligrams. So I would love to hear your thoughts on sort of field-based administration.
Yeah, so I actually took out a slide, or maybe it was just a bullet point about exactly that. Sorry, I did that now. I think a really key variable here is whether naloxone is active. I think that is the key distinguishing point. It seems like there's not a lot published, but from what's published, it seems like if naloxone is still active, let's say someone got Narcan in the field, as we would say, right? Like, if that naloxone is still active, it doesn't seem like patients precipitate withdrawal. So if you can harness that time period when naloxone is active and get a patient started, I think generally speaking, I'd be okay as long as that naloxone is still active. I think the literature is sparse, but sometimes you need to act. My biggest concern is more just about patient autonomy. That post-overdose period is extremely vulnerable for patients. And I find it really hard to believe. I don't know, I'm like someone who was trained as a specialist, and I like to pride myself on being, as up-to-date as I can and as patient-centered as I can. And I think, having a very hard time having a conversation with patients about, their desires to start bupe maintenance right after an overdose. So I worry a little bit that patients are going to be started on it without their full consent. But yeah, I just hope that's something that they're.
Yeah, and acceptance rates were really low in like the public, like they were 6% in the published study. So that sort of aligns with what you're saying, I think, that a lot of people aren't agreeing. So
yeah. So I actually, just since we are having this conversation, I think I will just go to my extra slide briefly, just to show some of these data on like, is the precipitated withdrawal risk greater with lower or higher doses of buprenorphine? I think it's still up for debate. I think a lot of the ED folks would say it's lower when you give higher doses. The risk is lower when you give higher doses. I'm going to make the argument here that I think limited data, but what data exists shows that lower doses are probably better. And I think a lot of this is based on one small study, but it was a really well done one from Rosado et al. On drug and alcohol dependence. Just at end of 10, but it was, the comparison was within the same person. So that's how they ended up getting a lot more bang for the buck in terms of like ability to make assumptions based on this. And they took methadone maintained patients and they gave them escalating doses of bupe until they precipitated withdrawal. And out of the 7 patients that finished that first one, they said, all right, let's say you precipitated after 8 milligrams. A week later, we're going to give you that same dose split up into 4 and 4. Or let's say it took you 16 to precipitate. We're going to give that split 8 and 8. I think it was 2 hours apart. And what they found was that split dosing generally produced less precipitated withdrawal compared to full doses in the same patients at, who were maintained on the same 100 milligrams of methadone. So it seems like lower doses seems like they precipitate less often. And then this is a paper, just an abstract where we're getting the paper ready to go. We looked at 160 hospitalized patients, standard bupe inductions, who had cows recorded both before and after. And what we found was that the incidence by the initial bupe dose, it was lower for the lower bupe doses and higher as you went up to 8 milligrams. It's consistent with this Rosado study and with what my anecdotal experience has been as well. So that's at least my pitch for, if you're concerned about precipitated withdrawal, lower doses are probably the way to go. All right. So we were at, how do you treat precipitated withdrawal then? What do you do if this happens? Right now, there's really very little evidence, but expert guidance suggests give more bupe. The goal was to start bupe in the first place, get them to that full dose. Some of these case reports show that patients seem to get better. In my experience, some maybe get better, some it doesn't seem to make a difference, but I don't think it makes anyone worse, generally speaking, once you have like that true precip. So I think it makes sense to at least try full dose. A lot of patients aren't going to accept more bupe because it made them feel really worse, right? So an alternative is to hold the bupe initiation, especially in the hospital, wait 24 hours, and then treat the opioid withdrawal with full agonists or with non-opioid adjuvants. And again, non-opioid adjuvants can be really helpful in this case as well. There has been some recent interest in using other medications. I think in the hospital where we have access to a lot of these, I do often give these patients a benzodiazepine, and that seems to make a huge difference in their experience of the symptoms. I know some folks at Yale have used ketamine and say that seems to work really well for them too. So all promising non-opioid adjuvants. And now, trying to tie some of this together, I guess, right? Like we've just gone over all these potential problems, saying it's hard to predict who's going to have a problem, lots of different approaches for what to do. So this is where I think having shared decision-making with patients is really important. And I always start with eliciting their prior experiences. So what happened? Most patients I talk to have tried bupe before. What happened? What do you think worked well or didn't work well when you tried it? And for all of our theorizing about receptor occupancy and timing and pharmacokinetics, like patient experience and expectation is probably going to be the most important piece of this. So responding to that is key. I think explaining what options you have, discussing adaptations that might be possible, making a plan, and then checking in regularly. This seems to be a really important part of it in my experience. Like sometimes it takes that phone call the next day, hey, how did the first few doses go? Or hey, like, what are you thinking about? They're still interested? Did you start it? Did you not take it? Working together with patients. So my approach right now, it's still a work in progress, but I'd say a traditional approach initiation should probably work for most patients still. In the context where I'm practicing, the pendulum has swung too far, I think, in the other direction, where a lot of clinicians I talk to won't ever do traditional starts, and they think like the only way to start is low dose, and I think that's a disservice to patients. I think most patients will be fine with a traditional start. I'd say wait a little bit longer since we don't know the exact patients will precipitate. Again, from that Rosado study, in our experience, I'd say starting with 2 milligrams is a better dose than 4 or 8 if you have the option. And I try to get them therapeutic fast. This is drawing from the high dose literature, saying once they get 2 or 4 and they tolerate and they didn't precipitate, I'd say just get them to that full dose. So that's maybe 4 more milligrams or 8 more, depending on what they got, to get them there. And then liberal use of co-prescribed non-opioid adjuvants. Then I have, the other set, which is actually the majority of patients I see who tell me they have a history of precipitated withdrawal, or tell me they can't tolerate any withdrawal or are not willing to try a traditional start. That's where I'd say consider low dose as much as you can. Simplify it, close contact with daily conversations, obviously having harm reduction conversations, if you're going to, especially if you're encouraging ongoing use. I would say my low dose initiation starts work like 20 or 30% of the time in the outpatient setting. I just don't feel that confident with them. So this is a summary on preempting withdrawal, using non-opioid adjuvants, low dose as an alternative, high dose, which I think of as a modification, how to treat precip, and then patient selection and counseling. I have some time for questions, comments, and more discussion. And if folks are quiet, we also have 2 cases we can go over, but I'll pause here. All right, well, maybe we'll just get going with the case and see if that spurs any discussion. So this woman, we'll call her Alicia, and she comes to your integrated primary care and addiction clinic. She, this is how opioids are sold in Philly as bags. So she uses about 4 to 7 bags of fentanyl daily. She sniffs, she never uses intravenously. She would like to start OUD treatment outside of an opioid treatment program. She strongly prefers to start at a clinic basis. And she's scared of bup because she said she tried it once from a friend and made her withdrawal worse. And all her friends tell her, oh, it'll make you sick. Don't even try. So what's your next step? Also, don't expect a slide with answers here. This is more just spurring some conversation. Next questions. I might have to call on someone, as much as I hate doing that, but yeah, I see 2 people engaged, potentially either David or Anna. If I could bug you to unmute, share.
I can share with the caveat that I'm like the fellow that's been here for 2 months.
Perfect.
She seems like if she's really, really afraid of the precipitated withdrawal, like maybe worth trying to talk to her about a very low dose initiation and continuing to use for a couple of days if she's like got really high anxiety about it. But I think also maybe trying to reassure her and use some pre-medication. Like maybe we can, if we had like the right support and she could contact us by phone or something, maybe do like a traditional initiation if we can just kind of bridge her to buy some time.
I think that sounds great. Yeah, I think that's kind of exactly the approach I would take too. Kind of asking some of these questions for her, right? What are her goals and priorities? Does she have any tolerance for even mild withdrawal? And then our global sense of her risk of precipitated withdrawal. This is going to be vibes-based risk assessment, I hate to say, not evidence-based risk assessment. So I sometimes get a sense that patients using less probably have less of a risk, and 4 to 7 bags is on the lower end, what we see here in Philly. So I put her a little bit lower end there. Heavy use often goes, concurrent with IV use. And I sometimes see also IV use patients seem to be at higher risk potentially. So maybe the fact that she sniffs, doesn't use IV, maybe puts her a little bit in the lower risk of precip there. I think if she has some tolerance for mild withdrawal, I think I would try to counsel her and talk about a strategy to try a traditional induction. And this is a setting where I might say, like, I'm happy to have you like go pick up the bupe from the pharmacy, bring it back to clinic here. And then, if you have the waiting room that's right for it, or the right setting for it, or open exam room, to say, hey, you want to just try taking it here? We can like try pre-medicating you, just kind of see how you respond, so she knows you're there for her, and you can kind of respond somewhat immediately and assess her right then, and whether it's reassurance or escalating care, you can kind of just see how she does with that first 1 or 2 doses. Yeah. Any other approaches folks would use here?
I'm curious, can you talk a little bit more about how you talk to people about their tolerance for withdrawal? I think it's something I completely agree. I feel like the wording, like I still struggle sometimes with wording and using terms that, and I think just like how we assess that, you know, and how patient, like I'm just curious how those conversations usually go for you and how you frame that question.
Yeah. I'm thinking out loud here, and I think I would start by saying something along the lines of, I mean, after asking more questions and try to assess their values, and then when it gets to the point where I feel comfortable just sharing what my assessment is, I would say something like, I really think a traditional induction is more likely to go smoothly. I might not say traditional induction, but I think the normal way of starting bupe might go more smoothly. It takes a few hours without using. I'd say at least 8, preferably 12. And then I think I'd ask, you know, over the last week or two, how often have you had 8 to 12 hours where you haven't had access or you haven't used? Because I think most of the patients that I see just they have chaotic access too, whether it's because of funds or their supply and the supply changes. So like I try to just go back to like, okay, what is their daily life like? And a lot of them I think have 8 to 12 hours where they don't use, not because of their preference, but just because they don't have the money or access to it. The opioids. So just asking like, how did that feel? What symptoms did you have? And what's the longest period you've had where you couldn't use or you didn't use, you know, over the past month or so? And what did that feel like and what symptoms came up? Maybe how I would start it. Yeah. Any other thoughts or advice other folks have? Okay. With a lot of these, I know I'm the speaker, so it's like oriented as if I'm going to be the expert here, but I'd love for others to share too. All right, and then we're mostly at time. I'll summarize what this case was. Just you're attending on the consult service. This gentleman admitted for injection-related wounds. The team and you can anticipate at least a 3 or 4 day stay for him, if not more like a few weeks. He uses a lot. We'd say like 1 to 2 bundles a day intravenously, which is not uncommon here. He'd like to start buprenorphine maintenance. He said eventually, or like, yeah, sure, I'll start Suboxone, as a lot of patients put it, but his priority is withdrawal and pain management. And this is a setting where I think more often than not, I would probably temporize this patient with full agonist schedule to treat the pain, prioritize treatment of the pain, and then at a certain point, either do a traditional induction if it's been at least 3 days from his last fentanyl use. I think that's the smoothest. Or you could do a low dose induction if the patient needs to be on full agonists at the time you want to transition him. But I think one of the smoothest transitions for him would be like full agonists, like scheduled hydromorphone for 2 or 3 days, and then last dose at midnight, start full dose of bupe 8 a.m. the next morning, and you're there. All right, we are at time.